Hello and welcome to the Innovation Theater hosted by T2 Biosystems. T2 Biosystems offers the first and only diagnostic test for identification of fungal and bacterial species directly from whole blood and independent of blood culture. Our first speaker is Dr. Pavel Drevinek from Czech Republic, who works within the Department of Medical Microbiology as the Director of Microbiology. Welcome, Professor Drevinek.
Okay. Thank you for the introduction and for inviting me and give me the opportunity to share our experience with the T2Bacteria panel in the clinical and real practice. So after my disclosure, I would start to introduce my hospital, which is name is Motol University Hospital, and it's the largest hospital not only in our country, but they say in Central Europe. So we have over 2,000 beds, 400 of them are intensive care, and we have altogether 28 clinical departments. There is highly specialized healthcare service for pediatrics in particular. And if you look at the map or at the photograph, there are two big buildings. One of them dedicated to the children's care, the other one to the adults care. And it's important to show that not everything is on one place, and microbiology, unfortunately, as a department, is quite far away. It's 1.5 kilometers from the main building, and it just indicates that there are some sort of troubles with the pre-analytic stage, as was yesterday nicely highlighted at the sepsis symposium. That is really important. If we want to use something which is like a POCT, rapid diagnostics, it should be used without any necessary delay, and the logistics is one of the delays which are there, but we shall find the ways how to overcome this. So our microbiological service is not surprising in the context of sepsis. So we use the blood culturing systems as a gold standard with all these pros and cons. And if it's positive, so we do the classical microscopy examination, then subculturing and identification of what the MALDI-TOF, and including the antibiotic susceptibility testing. Our research unit also, or it's a clinical research unit, is also very much interested in novel platforms. So we evaluate from time to time different promising technologies. So I'll show just two of them. From positive blood cultures, so there is the starting material is the positive blood culture, and we evaluated in the past the system Accelerate, which can bring up the MIC values, or the Biomaria system with the identification of bacteria within an hour, and also with some genes for antimicrobial resistance. So the next step in the microbiological service for sepsis is the molecular, and we use the whole blood sample for the diagnostics of pathogens in blood by using the broad range 16S based PCR accompanied with sequencing, with the Sanger sequencing once the PCR is positive. So we've published this in a paper showing that this platform can be applied not only to the blood but also to other material, and now it's been recently submitted the meta-analysis on the 16S based diagnostics from variant materials. In the past, we worked and we evaluated the system which is like a broad range PCR accompanied with the electrospray ionization mass spectrometry, but that's no longer on the market. So this very promising tool, I must say, is no longer supported. And we also evaluated the platform, which is the main topic of today's session, and that's the T2MR. So our pilot study was run and was published in 2021, if I'm not wrong. And at the time, so we piloted that on examination of 55 samples altogether. So you can see the general graph showing those 55 samples which were checked by T2 as well as by blood culture, and the classical categories for ordering the graph is proven bloodstream infection, possible bloodstream infection, and probable bloodstream infection. You can read the definitions of those three categories. And proven BSI is simply that you find the positivity by both systems, by T2 as well as by blood culture. And possible or probable is when you find the positivity by the tested system, so by the T2, but the blood culture is negative. But you can consider from the other information that it's a true positivity. So when we now focus on the data where the T2 kit was positive, so we altogether detected 15 samples positive, and we detected 17 findings of the bacteria which are part of the panel. So we know that the T2 bacteria panel composes of 6 different bacteria that can be detected by that panel. So when we focus only on those 6 bacteria, so we had 15 positive samples with 17 detections. So there is a quite easy comparison of the T2 with the blood culturing, and we can see that while T2 bacteria detected 16 out of these 17 detections, blood culture could detect only 9. There was, I must say, 1 false negativity with the T2 system, but there were 8 false negativities with the blood culturing system. Usually the question goes if the panel is sufficient enough for detection of bacteria from the bloodstream, because we know that essentially any bacterium can cause bacteremia, can cause the bloodstream infection. So is it enough or not? So in our graph, so we can now focus on all the positivities which were found, of course, by blood cultures only if it was off panel. So we detected other bacteria other than those which are on the panel. So you can see that there are some of the streptococci detected by the blood culturing system, some candida, and then a number of bacteria that were concluded to be blood culture contaminants. So if I summarize the data, so how much the T2 bacteria panel cover the detection of all possible bacteria in the bloodstream infections, so we can see that it's more than 50% of all the cases are detectable and were actually detected by the T2. And if we exclude contaminants, because contaminants made quite a considerable part of it, so it's more than 3/4. So 77% of positivities were detectable by the T2 system. And we missed just those which in principle we had to miss because it's the off-panel microorganism, but that the relevant ones were the streptococci, as I mentioned before, and candida panel. But it's fair to say that now with the T2 system, we've got also available the T2 candida panel. So if you run the T2 candida panel, you would be very likely able to detect those candidas as well. So from January 2023, our management as well as the laboratory decided to implement the T2 detection into the clinical practice as a routine part of the diagnostics of sepsis. So what we can do from the molecular perspective is the 16S-based sequencing as well as the multiplex PCR with the T2 detection. So at the very beginning, we had to set some rules because there is another big concern about these new technologies, and that's the cost, of course. So the sustainability of the budget. So we set the rules to make sure that we can actually afford the use of the T2 and use it for relevant cases where it makes sense to be applied. So what are our rules? It's the access to the examination is restricted to pre-selected departments, and I will show you in the next slide, so which hospital departments can actually order the T2 examination. It's indicated for patients with clinical and laboratory sites of sepsis. So this is very vague, but it's still helpful, and I will explain you later on, so how we actually consider this, that the sample is indicated for the T2 panel. And we insist on the parallel blood culture, and it's obvious, as I already explained, because it doesn't cover, the T2 system doesn't cover all the bacteria which can be present on the bloodstream. And also, if it's the case and there is one of the panel bacteria, you still need the antibiotic susceptibility test done. We, unfortunately, not the 24/7 laboratory, so we are available only on weekdays from 7 to 7. And at the time, we can guarantee that the result will be delivered at the same day. So if the sample comes to the laboratory at 6 p.m., and that's the time when we actually close the door, so we still can put the sample into the machine, and then automatically the result is released to the laboratory information system 4 hours later. So that's how we guarantee the same day result from 6 to 6. If the sample is taken off hours or on weekends, so it doesn't mean that it wouldn't be checked. It can be checked, and this is the situation when the blood culture is still negative and the patient is still in the situation that we need some sort of information. So then we double check this and run also the samples which were taken in off hours. So what are the results from January to 2023? So far, we tested 47 samples, and 16 of them were T2 positive. So the rate is around 34%, which is quite high and very similar to our pilot study. But this is the high because we pre-selected the department. So we actually, enriched the probability by taking the samples from those patient group where you can expect to have the real septic case. So the departments are on the table. So the departments that are allowed to order the test is the Department of the Anesthesiology and Intensive Care Medicine, Emergency Department, and several ICUs units for the Department of Surgery, Cardiosurgery, and Internal Medicine. You can see the number of tests ordered and the number of positives, and also which pathogens were detected for each of the department from the positive samples. So the very easy conclusions from this general information is that the emergency departments got the highest rate of positivity. And we are not surprised because if you got a patient with the community with the suspicion of sepsis, they are quite well indicated for the examination, and you got the result. So Staph aureus and E. coli are the most common pathogens from the community, so they are there found to be positive most commonly at the emergency department. Interestingly, co-infection rate is not low. We could see in 4 cases out of 16 the co-infection, which is quite important, but usually the co-infection was from the ICUs or from more complicated cases from patients who were already hospitalized for a certain of time, and there were some complications coming up. So now, case by case, I won't bother with case by case, but just to show you the granular data. First, on the 9 cases of the proven BSI. So the cases where the T2 result was, let's say, confirmed by the blood culture. So there is the underlying condition on the table mentioned, and of course the name of the pathogen detected by both systems, and then time to positivity, which is really important, because if you say that both tests do the same, so what's the difference? Why you should run another one if you've got the same result? But this is really important. That's the time perspective, and we can see the delay of the result from the blood culture is on average 20 hours. And still 20 hours means that sometimes you've got the information based only on the microscopy, so that by the time the blood culture based diagnosis can say, yeah, there is gram-positive, gram-negative clusters or chains. So sometimes only microscopy, sometimes is the preliminary identification, and it depends on which time of the day at the laboratory the positive blood culture is examined, because sometimes lab staff is ready for do the identification and sometimes they can do just the microscopy. What is also important to look at is the management for patients. If the T2 system actually have any impact on the therapeutic level. And you can see that roughly 50% of cases where so the change of antibiotics was indicated thanks to the T2 system. So when we look at the probable or possible bloodstream infections, so that's the case where there is no blood culture finding. So blood culture is negative, but you've got the T2 panel positive. So we had altogether 7 such cases, and that's interesting to look at the bacteria which were detected by the T2, not by blood culture. And if we look at the changes in the therapy, so it's just a good indicator that the findings of the T2 panel was relevant, that clinicians took it seriously and clinical microbiologists as well. And based on the results, they adjusted the antibiotic therapy. It's fair to say that there were also cases of the false negativity, and that's always the issue. And people ask, you know, you've got this very fancy new platform, so is it really 100% accurate and all the time? And we can say that throughout all the platforms, you can't get 100%. You know, the accurate identification. So there were false negative findings, but interestingly, both of them were very difficult cases. Both of them were fatal cases. The patients die within 2 days after the diagnosis of the sepsis. And in one case, it was E. coli, and another case was Staph aureus positivity by blood culture. In our pilot study, we also already faced the false negativity. It was one case where the sample was negative by the T2, positive by blood culture, and that was E. coli. And when you look at the limit of detection of the T2, which you can find, you know, on the description of the system, you can see that there is, of course, the limit of detection, and for E. coli is the highest. It's the 10 coloniform units per milliliter. So that's something that E. coli would be probably one of the potentially, you know, problematic bacteria that can't be missed because you have the limit of detection a little bit higher than the rest. All right. So now, when we started to use it in diagnosis, and I mentioned that we selected just some of the departments to allow them the testing, but still we need some, you know, better guidelines in a way to say, so which patients are indicated for the examination, and to say clinical or laboratory sites of sepsis, as I said previously, it's vague. So we looked back to the T2 Biosystems guidance to find some clues which could be helpful. And there are some, of course, very good advice, but sometimes it's, of course, again, very general, you know, suspect bloodstream infection, septic shock, so suspicion on that. What we found very useful, and that's preferentially for the emergency department, is the Q SOFA, and the clinicians use it. So that's a very good indicator that the patient is in the septic state. If you have the Q SOFA coefficient, you know, the score high. And also you can have a look at the procalcitonin levels and the lactate. So we look at that. But first we check the most common indicator used for the bacterial infection. There's a CRP, and as everyone would probably guess, CRP, sorry, I'll go back. CRP was of any help. So you can see that there are higher levels of CRP and negative results of the, it's a game with that. Okay. Okay, so CRP, you can see that there is low levels of CRP and positive blood, and positive T2, and then high CRP and negative T2. So you can't use T2 much, sorry, not T2, CRP much as a, I don't know what's going on, sorry. So hopefully that will be stay for a little while. So there are the other two markers, and it's the procalcitonin and lactate. And according to the guidance from the company, they say it's less than 2 or above 2. And you can see that procalcitonin alone, again, there is uncertain, and it's not that much helpful. You have no statistical significance, between 19% of positive cases for procalcitonin below 2, with 31% of positive cases with procalcitonin above 2. Lactate is a little bit better marker, so there is already the tendency to see a higher rate of positivity for patients who have lactate above 2. And if you can combine both markers, PCT and lactate, so it's marvelous, because then you can see if a patient's got both positive, there is a very high probability that the T2 bacteria panel would be positive as well. The trouble is that clinicians don't use them in all cases. So it's not like that every single case would have the markers checked, and that's something that we need to discuss with the clinicians if they can indicate the biochemical septic markers along with the T2 system. So in conclusion, the T2 magnetic resonance is the only commercial available platform that allows detection directly from blood samples. And we can see, and I showed you, that it can cover more than 50% of all bloodstream infection cases. If you take into account contaminants or you exclude them, it would be even more. It would be more than 75%. High sensitivity, as it was already confirmed by the registration study, where almost 1,500 samples were tested with the positivity rate of T2 magnetic resonance with 9% and blood culture with only 3%. So you can see that as much as or three times more cases were found positive by the T2 system compared to blood culture. Our published data show that we were able to detect 27% of cases by T2 and only 16% by blood culture. And our routine use showed a very similar trend, 34% of positivity with the T2 and 23% with blood culture. There is a significant reduction of time to result in these proven BSIs. So as I already mentioned, 20 hours delay can be overcome by the use of the T2, because these 20 hours it's the time which is taken for the blood culturing system. And the change of antibiotic therapy, it's quite common. So in 50% of all cases, the clinical microbiologists in consultation with clinicians change the antibiotic therapy thanks to this on-time result from the T2. T2 is not a broad-range approach, that's clear, and the negative panel result does not exclude the possibility of BSI, so that's one of the reasons why we still insist on the parallel blood culturing. And the false negativity can occur. In our experience, we faced 2 E. coli false negative samples, 1 Staph aureus negative samples out of 100 samples examined by the T2 so far. In the registration study, if I'm not wrong, there were 4 false negatives out of those 1,400 samples, so it was like 10 times lower. And we are very, of course, curious to see what will be the trend with the more samples examined in upcoming months. So what are now our next steps, and what we already started to do is actually, because of our very good experience with the T2 system, to expand its usage and to offer it to other departments, but we must identify the departments which it makes sense to use the T2 system. So what we've actually started to do, so we search in our laboratory information system the situations where the blood culture was positive for any of the on-panel bacteria, and that blood culture or that patient wasn't indicated for the T2. So it was unnecessary delay in the diagnosis. If we apply the T2 in parallel with the blood culture, we would get the result earlier. So we looked at the data from those departments which were already allowed to examine that, and there was a very little missed cases. You know, it was like maybe 4 or 5 cases, but we could see that internal medicine in general, not only several intensive care units, have got more candidates for the T2, and that's what we want now to do, and that's to offer the T2 for the huge internal medicine department, because in our eyes it looks that this is definitely could be very useful. So at the end of my presentation, I would like to thank to people from my laboratory, from the medical microbiology department, also the colleagues from the clinical departments, from those several ones who are very proactive and very keen to check the new technologies and to find the room for the usage. And of course, I would like to thank the T2 Biosystems for helping us with the pilot study, and the Biomedica as a local distributor of the system as well. Thank you for your attention.
Thank you, Professor Drevinek. I think we'll take the questions at the end of both sessions so that we have enough time. And our next speaker is Professor Özenci from Karolinska University Laboratory. He's a senior consultant, and his research focus is also to improve clinical microbiological diagnostics. So thank you so much for being here.
Thank you. Yeah, I'm working at Karolinska University Hospital, and we are taking care of 6 tertiary care hospitals in our laboratory. I have many disclosures, so I don't have any bias here, but none of them are private. All goes to these studies. The content is, I have actually 5 main questions for this talk, and I will try to go through one by one. The first one is the story of the patient with BSI. As you see here, there are 3 phases: pre-analytical, analytical, and post-analytical. And as Pavel mentioned, all parts are important, so you cannot miss one part. Although much focus has been on the analytical part, and I will talk about the analytical part, which is extremely important as well, so that we are not obsolete as clinical microbiologists. And the second thing is, do we really need clinical microbiology for bloodstream infection treatment? And this question came out from an ID doctor who was working with me, and he told me, oh, should I call all these positive blood cultures? They are already on treatment. And I told him, let's make a study of that. And I was very anxious that the study will show that we are obsolete. But luckily, despite the fact that we don't have much resistance problems in Sweden, the results show that actually 90% of the patients are on treatment at the time of blood culture sampling, but only 67 are on effective antimicrobial treatment. I'm not talking about the much broad spectrum antibiotics, which is not necessary, but effective antimicrobial treatment, only 67%. And on top of that, 70% of the patients are on treatment despite the fact that they have contaminants. So we are still relevant as clinical microbiologists. And then all these studies that I will mention are our own studies, so that I can discuss that. This is a review article that we published together with my colleagues in Mayo Clinic, and we discussed the analytical phase flow. We have culture-based methods for quite some time that I will come back to, but non-culture-based methods are very, very limited. And the next part is Dr. Littman published the study in 1910 with the blood cultures, and 113 years later, we asked the questions, are they really relevant? And then we asked the question in this study, and then we went through all different types or 2 different types of sepsis definitions. And as you see here, we are not talking about blood culture bottles here. We are talking about bloodstream infection episodes. And all in all, the maximum hit was 39% positivity for a blood culture, despite the fact that the patient has sepsis 3. And in average, it's like between 30 to 35%. This is not good. So 75 or 65% of the patients have no positive blood cultures, but they have clinical sepsis. So we need new tools to solve this major problem. And then we published a review article together with my colleague, Christopher, where we described these non-culture-based methods that are available. We published a number of articles with Iridica. We've been using it intensively, and at the end of the period, we wrote an article about the Iridica because, as you know, it vanished from the clinical routine, and we were very sorry about that. And I hope it will not happen to T2 because it's the only FDA-approved system today. So the T2 system, as you know, has its own panel, one for Candida and one for bacteria, and it's not easy to compare that to blood cultures. You need other data, as Pavel mentioned, to convince that these are not false positive results. So what we did is to check blood cultures, beta-D-glucan, and then other cultures, plus minus 7 days, but it can be longer periods that we can discuss later, and clinical and radiological diagnosis. We had 2 studies to convince Karolinska that it can be used in the clinical routine. The first study was about the T2 Candida assay. We had a selective group of patients with possible intra-abdominal candidiasis, and it's a multi-center study from Stockholm. I will not go into detail in this study, you can read the paper, but as you see here, if there is a candidemia, T2 detects it. And if there is no candidemia, it may miss it, and the beta-D glucan can catch that. And the negative predictive value, which is extremely important, is very, very high with T2, and this is used to stop prophylactic treatment, for instance. And the conclusion is it's fast and high specificity, and it can alter antifungal treatment, and it should be connected to beta-D glucan, because as you know, beta-D glucan is the golden standard for probable invasive candidiasis. So the next study was on T2 panel together with the T2 candida and T2 bacteria. As you see here, the detection rates are very high for T2, much higher than blood cultures, and we can support it with other relevant cultures. So it's a sensitive method. And if you put it simultaneously with blood cultures, and you get some interesting results if you have very sick patients. As you see here, we had no simultaneous candidemia and bacteremia in blood cultures, but we had 4 patients that were detected both with T2 candida and T2 bacteria. And all 4 were clinically relevant. So they had a polymicrobial infection according to the clinical data. And conclusion from this very study says that T2 is fast still, accurate in diagnosing on-panel bacteremia, and combining the two, if it is necessary, even though it's very, very expensive, but being expensive is something relevant. Each ICU day in Sweden costs like 5,000 euro. So it can be used in sick patients. And the last but not least, our ongoing study where we have real-time data. This is extremely fresh data, so we are working on it. And as you see here, so far we ran 838 samples for T2 candida and 505 for T2 bacteria, because we started earlier with the T2 candida panel. I calculated a little bit, and it's around 1.85 samples per working day for T2 candida and 1.74 samples per day for T2 bacteria at Karolinska. This is the summary of T2 candida panel. As you see here, we excluded some samples because we received it from other hospitals, from other cities, and then we exclude one sample here, which is not a blood. I know that it's almost forbidden to run other samples, but we did that because there was a patient with candida meningitis. The patient had candida meningitis before, and the patient had symptoms for that. We couldn't detect it with culture, we couldn't detect it with our own in-house PCR, and I decided to use T2 candida, and we could detect it so that they could start treating the patient, which is very, very important, and it's the future probably. And we included here samples. The positivity rate is 7.2, as you see here. And male, female, we should always look into this gender bias because we saw it in our blood culture volume study. As you see here, there is a kind of no discrimination, at least for this part, because the positivity rates are fair and the percentages are according to the prevalence of sepsis into genders. As you see here, detected species, Candida albicans is dominating here, and the others, we have 57 positive samples so far, and some polymicrobial. And this is the concordance rate with the blood cultures. We are working on that. As you see here, there are 35% of the results are concordant with the blood culture, but 61% we can detect only with T2 candida. And then there are some discordance. We didn't analyze yet the T2 negative blood culture, positive ones, but we don't think that there are many. But we are working on that. And this is the T2 bacteria data, 505 samples so far, and the positivity rate is 9.1, and as you see, some polymicrobials here as well. Something very important, the invalid test result rate, which is very low. based on these type of advanced methods. And here we have the female-male ratio. So previously there is no statistical difference in positivity rates, which means that there is no selection bias when they send the samples, at least so far. And this is an interesting picture, I think, because as you see here, the most prominent bacteria, E. coli and Staph aureus, are not the majority here. Here we have different data than the published normal blood culture epidemiology data. Why? Because we have special patients here. This is a selection, of course. They don't send samples from each and every patient as the blood cultures. The concordance rate here is 46%, 31% T2 positive T2 negative blood cultures, which is very, very high, and it is almost the same levels as the Eurydica. But here there is a limited panel, of course. And then these concordance rates are 21%. You can see the paper coming. Here, the conclusions, overall conclusions are, there's a tremendous improvement in analytical phase over the last years. T2 is an established method, and it is established in the clinical routine at Karolinska with high specificity and sensitivity. And it is also easy to use, which is extremely important. If you run a lab 24/7 as we do, and we would like to perform T2 even in weekends. Acknowledgements, this is my research group. Anna and David has been working with the last study, ongoing study, and our colleagues at Microbiology Lab. Mons Ulber, my previous chief manager. You can have wonderful methods. If you don't have a wonderful manager, then you can implement it. So that's very important. Thanks, Mons. And then Ulla Bleno and others are my colleagues from the ID department where we performed the study. Simrat helped us collecting the data. Anna Karin and Ingrid established the method. They are lab technicians, and they are also extremely vital to establish important methods. And then Meryl, Stefan, and Oscar, we've been communicating a lot, who are working at T2. They helped us a lot when there were problems and when we need help with the studies, like the reagents and so on. But now the T2 is in the clinical routine, and we are working on that. I would like to end my talk with this beautiful city. I'm the president of Nordic Society for Medical Mycology, and we will have our Nordic Society meeting soon in Copenhagen. So if you want to see the city a little bit more, you are very welcome in September again to Copenhagen. Thank you very much.
Any questions from the audience at this time?
For both of you, are you considering to test simultaneously? A bit closer, a bit closer. No, no.
Okay, you heard the question, don't you? Or you didn't? Okay, the question was if we are planning to use the resistance panel as well. The thing is that Sweden have very low resistance levels still. 15% ESBLs in blood cultures and 1% MRSA in blood cultures for Staph aureus. So I don't know yet. And we perform other types of rapid ASTs like the UCAST AST. So this might be an option, but we need to see the algorithm. We need to convince ourselves first as the studies and our managers and our clinicians. Yeah, south of Europe, Spain, Italy, Turkey, where I come from, it might be extremely vital to have this result early. Like if the KPC levels are 50%, then it's of course very, very important. Thank you.
Hello. Did you? I might have missed it, but did you say which patients you select for T2?
That's a very relevant question, of course. We performed a study in these ICU patients and high-dependent patients, surgery patients, intra-abdominal surgery patients, and we told them that, okay, these are the guidelines, and you know, if you say that, oh, send from all patients, no one will send you samples. If you put the guidelines clearly, then they will send other relevant patients, and we do receive samples from even from ER sometimes. But almost all the samples are relevant. They are not, they know the price, and they know that we don't accept too many because it was, but we have very good communication with the clinicians at Karolinska. And, but as I showed you, we use it even for cerebrospinal fluid.
Can I add to something? So you could definitely, you could mention, spot that there were differences in the cohorts of patients among our hospital and your hospital, and it also was reflected by the number of positive bacteria, you know, so we had E. coli and Staph aureus as the most common ones. You had the hospital-acquired infections in there. So it heavily depends on really the indication criteria and what's your priority in your hospital settings. We know that the emergency department doesn't take that much samples for septic investigation, and they've got the patients with sepsis. So there was a huge delay in the diagnosis. So we put lots of effort into the emergency, and think of it, use the system from the very beginning when patient admits the hospital, and by the time the patient is referred to some of the hospitalization to the department, they got already back the result. It's E. coli, it's Staph aureus. So we found out very useful, actually more useful than for patients on the intensive care units already, who are covered by the broad spectrum antibiotics and quite, well under control. So the emergency was our priority, you know, where we focus on implementing this system.
Yeah, I think it's completely dependent on the area, the clinic, and the routines. And I think we are planning a study right now with the help of artificial intelligence and algorithms. I think I asked the question 5 years ago, and it was not possible. Now it's a little bit more possible, and I hope we will collaborate with all these new state-of-the-art methods that we put an algorithm where you put the data, it will tell you that you need a better method than blood cultures. And I hope we will help patients better in near future with that.
Thank you so much, and thank you everybody for attending today's talk.